A 3-year-old boy is evaluated for recurrent ear infections, pneumonia, and chronic diarrhea. Examination shows cervical lymphadenopathy and mild hepatosplenomegaly. Laboratory findings show hemoglobin 12.6, normal range 13.5 to 17.5, leukocytes 8,700, normal range 4,500 to 11,000, platelets 290,000, normal range 150,000 to 400,000, IgM 4,000 milligrams per deciliter, normal range 50 to 300, IgG 15, normal range 650 to 1,500, IgA 5, normal range 76 to 390, IgE is not detected, with normal range 0 to 380. A phytohemagglutinin test shows normal findings, and a flow cytometry shows a normal number of CD19 B cells. Which of the following molecular deficits is the most likely cause of this patient's condition? Choice A, mutation in BTK gene. Choice B, deficiency of adenosine deaminase. Choice C, mutation in CD40 ligand. Choice D, defective MHC class II expression. Choice E, mutation in STAT3. I'll wait 5 seconds and begin answering the question. So, pretty easy question here. You got a boy with recurrent infections, and even if you weren't already thinking it, all the answer choices are pointing you towards some kind of immunodeficiency. Very straightforward because this kid has cervical lymphadenopathy, which tells you that the actual lymphoid tissues are fine. You got this immunoglobulin breakdown, which tells you IgM is really high and all the other ones are very low. Very easy diagnosis of hyper IgM syndrome. And you look through the answer choices. Choice C, mutation in CD40 ligand, also known as CD154, is the correct answer. So a quick review. When a B cell wants to switch isotypes, it needs to connect CD40 to CD40 ligand on T helper cells. So of course, if I'm missing CD40 ligand, I can't undergo isotype switching, and by default, B cells can go into IgM secretion. So that's all it's going to do. So that's why you get this very high IgM secretion with very low in all the other immunoglobulins. So as for some of the other random bits of information in the question, a phytohemagglutinin test, that's not really something you necessarily need to know. Just know that it's used to test cellular immunity. So basically this last line in the question here is saying the T cells are fine. And it's also saying that the B cells themselves are fine in terms of population. Which makes sense, right? There's nothing wrong with the existence of B cells in hyper IgM syndrome. It's just that they can't isotype switch. Anyway, other answer choices. Choice A, mutation in BTK gene, that's Bruton's or X-linked A-gamma globulinemia, causes failure of pre-B cells in the bone marrow maturing into pro-B cells because of a mutated tyrosine kinase. That's what the TK stands for, Bruton's tyrosine kinase. Usually presents with recurrent bacterial infections because you have a lack of humoral immunity. On physical exam, you're going to have scanty or absent lymphoid tissues. So it won't be like here where there was a cervical lymphadenopathy. That probably wouldn't happen on Bruton's. Okay, choice B, deficiency of adenosine deaminase. That is one form of autosomal recessive SCID. The lack of adenosine deaminase can result in a buildup of deoxyadenosine. It's toxic to a number of your cells, including your T cells and B cells. So you'll end up with a complete absence of B and T cells. SCID shouldn't be too hard to diagnose most of the time. Complete lack of B and T cells, so you're going to have recurrent bacterial, viral, and fungal infections. Basically, everything bad can get you. Failure to thrive. You'll have scanty lymph nodes, and you also have absent thymic shadow. There are other forms of autosomal recessive SCID, but the most important one is adenosine deaminase deficiency. The other one that USMLE likes testing on is X-linked SCID, which is a common gamma chain mutation. So the common gamma chain is used for a number of receptors, most importantly for the interleukin receptors, most notably interleukin 2, which if you know your interleukins, interleukin 2 is very important for T cell development. So basically you end up with a failure in interleukin signaling. So next we have choice D here, defective MHC class II expression. So this is technically considered another form of SCID. This is Barrett lymphocyte syndrome type 2. So without MHC2, antigen-presenting cells can't present their antigens to CD4 T cells, and it leads to a SCID-like presentation. But obviously, if you think about the mechanics of it, that's just a problem with T cells performing their function. So in Barrett lymphocyte syndrome, usually you actually have normal amounts of T and B cells. It's just that T cells can't perform their regular duties. Now, in type 2, because it's about MHC2, of course, CD4 T cells would be deficient. There's also, of course, Barrett lymphocyte syndrome type 1, which would be a deficiency in MHC1, in which case CD8 plus T cells would be deficient. But Barrett lymphocyte type 2 tends to be more severe. So, like I said, Barrett lymphocyte syndrome is technically a form of SCID. And when we're sitting here talking about SCID, usually you'll hear people talk about, as I mentioned, X-linked SCID, which is the gamma chain mutation, and adenosine deaminase deficiency, which is the most common form of autosomal recessive SCID. The other forms, like Barrett lymphocyte syndrome and some other ones I've seen as answer choices like JAK3, they show up from time to time, and I don't think it's worth your time or very efficient to go and memorize every single form of SCID, obviously. Obviously, if you have a bunch of extra space in your head and you want to go learn all the SCIDs, that's your freedom. But it's probably a much better use of your time to be more familiar with all the other forms of immunodeficiency, and that will help you answer questions more effectively. And that brings us to choice E, which is STAT3 mutation. That's hyper IgE/Job syndrome. This is also a relatively low yield condition. I would still know it. It comes up from time to time, probably more than the rarer forms of SCID. Hyper IgE syndrome is characterized with faded, FATED. F is for coarse facies, A is for abscesses, usually staphylococcal, T is for teeth, as in retained primary teeth, E is for IgE, and D is for dermatologic problems. There's usually a rash that's kind of like an eczema-like presentation for hyper IgE syndrome. So bring it back. Hyper IgM syndrome, lack of CD40 ligand, causes lack of isotype switching in B cells, leading to very high IgM and very low all the other immunoglobulins. Out of the immunodeficiencies, I would say this one is one of the most high yield ones out there. I mean, there's a lot of them I didn't even mention in this video so far, but I probably shouldn't try to overwhelm any of you who are early on in your prep. I hope you found this video helpful. I'll see you in the next one.